mental health in later life, taking a life course perspective. And I was very honoured when Alisoun asked me if I would write the foreword to the book. In the foreword, I mentioned that the book was timely, but in fact, in many ways, the book was long overdue. I won't go into lots of detail here, but the subject area has had little exposure over the years, so it was the right time to do that and to really bring the book to the fore. And the importance, I think, of mental health and the life course and older age has been starkly highlighted by the current pandemic crisis. And I think this book will take on extra significance viewed through the COVID lens. I can see a follow-up book coming, Alisoun, second in your trilogy probably coming through. And although this was written before the crisis, I think the inequalities exposed through the impact of the pandemic are very much illustrated in your book. So it's fantastic that the book has come out. But what's the USP? What's the additionality to the literature that the book contributes? I'd like to highlight three particular things where I think the book makes a very refreshing and a must-read text, actually. So your summer reading, as you probably won't all be sat on beaches this summer, but at home, this is a great read. And there's three reasons I'd like to highlight. First of all, the book starts a conversation about the intersection of aging, mental health, and inequality from a life course perspective. So the consequences of childhood stress and abuse, the role of socioeconomic disadvantage, the relationship between physical and mental health, and the consequences of all these factors for later life, very distinguished in the book. Secondly, the interweaving of a human rights and social justice perspective. I think a very fresh way of looking at mental health rather than focusing on a very traditional nihilistic approach that has really permeated both the literature and dominated practice. And I know, Alisoun, as a social worker, you will have come across those kind of perspectives at first hand. And thirdly, a number of the chapters explore the lived experience of older people, sometimes through their own voices. And I think it's this focus on the lived experience that is central to the recalibration of mental health in later life in a new paradigm, which Alisoun illustrates and is in the final chapter of the book. And I shall leave Alisoun to tell you more. I don't want to steal her thunder on all of this. So thank you very much. And I'd like to introduce you to Alisoun Milne, everyone.
Thank you very much, Judith. Right. I hope you can see slides. Yes?
Yes, okay, Maya.
Good. Okay, thank you very much indeed, Judith. That was really helpful and positive, and I really appreciate you giving up your time to do that for me this evening. I just want to spend literally probably about 3 minutes highlighting 2 or 3 key issues in relationship to my book. The first issue I just want to cover is, like, why did I do it? I won't lie, it was a real lot of work writing. It probably took me the best part of about 6 or 7 years to write it. So it was not a lightweight undertaking. And one of the things that drove me forward was a passion for wanting to bring into the foreground issues relating to older people's mental health. I think there has been and remains, although we'll come on to why that might not be the case quite so much in a moment, a lack of political policy, service and public attention paid to older people's mental health. And I think it was also a recognition of a significant gap in the literature, and Judith highlighted this as well. There is quite a lot of literature on mental ill health, particularly dementia, but functional mental health problems too. Even books that have in their title mental health are often not. They often end up actually being about mental ill health. And one of the issues that colludes, if you like, or confirms, is that mental health issues in later life are a product just of later life. They're related to being old, to being ill, perhaps to being dependent. There's a tendency to think about older people's mental health issues as just being located in the end stages of life, and the causes as being related to being old. That sort of nihilistic, what can you expect at your age kind of attitude. So that was a third issue for me. A third reason for writing the book was to challenge some of that thinking, that narrow discourse, that rather nihilistic narrative. And I think the fourth driver was a recognition that there was a lot of evidence out there in psychology, sociology, in medicine, from user-generated sources, and in the rights domain, as Judith highlighted, that intersect with issues relating to mental health in later life, but hadn't been brought into a single place. So bringing evidence from a number of different sources together to explore and explain the issues that undermine or promote mental health in later life. And there is a fifth issue, which was about bringing the lived experience, the voice of older people, into that discourse, which again Judith mentioned. So the book was informed by really I adopted three lenses, I suppose is what you'd say, in terms of how I explored and interrogated the literature, the evidence out there. The life course approach Judith's already talked about, and that really is the platform, the key platform upon which I think my book rests. The critical gerontological perspective is also key. It explores age as an individual experience and a product of social structures. And aging is situated in historical time and in culture and in a socio-political context. And old age itself as a conceptual status and a political entity. And then the third lens is, I'm not sure if you call it an approach, it's a framework, I think, or a way of understanding the world. Work focusing on social and structural inequalities and how these relate to health outcomes, mental health outcomes for my book. It draws attention to the ways that issues such as gender, race, and socioeconomic status influence mental health outcomes across the life course and in later life. And I hope I've offered a kind of fusion of those perspectives in my book. I want to turn now, I've got just a couple more slides, where I'd like to sort of, as Judith hinted really, the COVID-19 pandemic has in fact exposed key inequalities and key issues in relationship to both physical and increasingly mental health. And I just want to, as it were, make my books issues very, very current, bang up to date, and highlight some of those agendas. I did a blog, by the way, which I'm hoping Rasa will, a blog called The Impact of Corona Confinement on Older People's Mental Health, which I'm hoping Rasa will put a link in the chat room for you to follow if you're interested. So just a couple of facts. So COVID-19 has enhanced the risk of some groups of older people being exposed to poorer mental health outcomes. I've got two examples here. We know that at least 1.5 million older people are self-isolating, trapped indoors, which enhances their risk of loneliness. And loneliness, particularly persistent loneliness, is related to increased risk of anxiety, depression and suicide, almost a solitary confinement actually for some older people. That's how it's been described by them. And then another group, and again, if you've kept up at all with current press and COVID-19, you cannot escape to notice that there's a whole host of issues in relationship to care homes. I mean, our dear Prime Minister has not covered himself in glory of late, talking about them being perhaps to blame for the problems. But in terms of mental health, there are a number of issues that intersect to impact on the mental health of care home residents. Being trapped in their rooms, unable to leave their rooms, reduced contact with staff, perhaps even the staff not being there, themselves having to shield, no visits from family or friends, and the constant presence of death and fear of dying. And what we do know is that a lot of older people in care homes died alone without the comfort of staff or relatives. But what I think is particularly interesting about this really is that those risks were not created by the virus. They were already there. And as Gilliard and Higgs say, the virus acts like a magnifying glass, amplifying but not fundamentally altering the unequal nature of aging and the impact of life course related inequalities. And we know, for example, that a life course characterized by poverty and disadvantage significantly increases the risk of older people experiencing loneliness, stress, anxiety, depression, and actually there's increasing evidence about dementia too, which I'm happy to go into if somebody wants to ask a question about that. But again, challenging perhaps the biomedical narrative that this stuff is related to age and to decline. But just to reinforce, so the pandemic has heightened a lot of these risks, but it didn't cause them. They were already there. It amplified them. And in thinking about the new normal, if you like, or a new way of thinking about addressing mental health issues, I've called it refocusing the lens. And again, as Judith highlighted, my book very much echoes, or rather the British Medical Association, the Centre for Mental Health echo me in highlighting the importance of three key issues going forward. The first is addressing inequalities. So perhaps the pandemic has offered us all an opportunity to address newly exposed or exacerbated health inequalities. Comprehensive action is perhaps now required on the social determinants of mental health. Poverty, poor access to education, and childhood issues, midlife issues that carry through and amplify and intersect into later life, amplifying risks. And then the second issue is what I would call a public mental health approach, and indeed so does the Centre for Mental Health, spanning prevention, promotion, and effective treatment and care across the life course, including upstream interventions. So tackling childhood socioeconomic disadvantage. One of the most depressing things I think I read in relationship to gathering evidence for my book was that a very disadvantaged childhood, the health-related consequences of that childhood can never be deleted. You carry those disadvantages, the poor diet, the psychosocial stress throughout your life. And I think that is a particularly depressing conclusion, and this is evidenced. So we need to tackle issues across the life course that then have implications further downstream. And then the third thing, which I don't know anyone's quite said, well, the British Medical Association hasn't quite said it, is I think there's an increasing emphasis on the importance of relationships. What's been clear in the crisis is that people miss people. We need to see each other. We need relationships in our lives, in our families, in our communities, and in services. And one of the most striking things I think we could, all of us who work in the service sector, who train people who work in the service sector, in social work and social care, is we could make much more of the fact that what matters to older people who receive care in services is relationships of trust, not having lots and lots of different carers, not having different social workers, the same people. So I think it's shone a lens on the importance of those issues. Right, and lastly, I've got to tell you that if you want to buy the book, you get a 30% discount up until the 15th of July. So please make a note of that code. I think that's all I'm going to say. You've got to read the book to find out the rest. Right, I'm back in the room.
Excellent. Well, thank you very much, Alisoun. There hasn't been any questions posted in the chat yet, but I'm sure people need a moment to think about things. and I can't see anyone with reactions, either raised hands or thumbs up or anything else to indicate they'd like to speak. You can speak now, or else I have a question. And Joe, please.
Hi, thank you. Hi, everyone. And thank you so much, Alisoun, for that. And many congratulations on a fantastic achievement. I know what hard work it has been and how much you put into it. Inevitably, my question relates to politics. I mean, it probably represents, I'm sure you would agree, one of the single most dramatic examples of political failure policies directed at this group. What do you think can be done? Where is the impetus going to come from for political change? And obviously, specifically in the context of what will be a pandemic economy for probably the next, God knows how many years.
That's a very good question. So if I got it right, where's the impetus going to come to think about the issues I talked about in my last slide? Is that what you're saying politically? Who's going to pay any attention to those issues?
What I suppose, what can be done? What can we do? Where's the pressure going to come from? Given that we've all been, people have been trying for so long. Pressure has come from all sorts of directions, particularly from the academy. All the evidence is so clear. There are so many very wise and knowledgeable people that know what needs to happen, and yet it just doesn't seem to happen.
And that's a really good question. I mean, I think there are a range of ways. I'd value Judith's input on this, actually, because I think it's a sort of issue that she would have thoughts on. I mean, I think one of the issues the care home issue, I think, is a real crisis. And I think we should, all of us, take advantage, if you like, of the fact that there is real concern across the country. It is not just something that happens in your community quietly without anyone paying any attention to it. It's almost as if the crisis has opened up the doors, excuse the pun, on issues that were already there, but have been writ large in the crisis. And I think there has been a lot of concern about the number of deaths. It feels to me a little bit like it's slightly going off the boil. If Mr. Johnson continues to totally upset the care home sector, I think it may continue to be the case. And certainly I know of 2 legal challenges that are currently being mounted against Dominic Cummings and against the Health Secretary. The latter is in relationship to families who were denied the chance to go and visit their relatives on their deathbeds in care homes. So I think there are going to be some legal challenges which will challenge, if you like, the issues that happened in care homes. But you're asking a much bigger question, aren't you, about the political agenda? I'm not sure about that, Joe. I think it's an excellent question. I mean, my book is basically a political treatise, if you want. It's saying that actually mental health in later life is a political issue. And the more we construct it, either as a biomedical problem or just as something that happens to a bunch of old people for reasons that are to do with being old, the further we shift it away from it being about politics. I mean, one of the things I find frustrating is that people who are quite chronologically old themselves, who work in environments where they could influence policy about aging, often don't, partly because they belong to a society that would construct them negatively for being old. That irritates me a bit. The feminist lobby I would be critical of in that regard, for example, although they're beginning to be a bit better. Judith, do you want to have a shot at that question? It's a bloody good question.
It is a good question. I think you've answered it well, actually, Alisoun. I mean, I find it quite depressing. I think, I'm just waiting for the whole thing of social care to go back in its box, because I think certainly the politicians will want to see that. I think this view of we can fix social care, it just shows how naive they are about the situation. And I do think that I'm really worried that it will just, be something that today is on the radar and tomorrow isn't, because there are so many other issues. So that's my fear and worry. And I think the more we can politicize it, the better. and the more exposed, certainly the inequalities that there are. I think one of the ways to influence is to really tap into quite a lot of their agendas. So, you know, on the inequality one, the levelling up is very much a UK government concern. So really trying to address that and to expose those inequalities, but coming up with solutions, I think. I mean, government are desperate really for answers. And I think if we can come up with some answers, but it's having the influence where the power is. And, you know, I think from my perspective, that is really been drawn into number 10. I mean, it's the Dominic Cummings, Boris Johnson roadshow, basically. And I think, how do you actually, you know, have any influence at that level? And I think I'm depressed about that, actually. I think we're in a situation where, you know, we have to sort of manage to get to know the key people who are around the power to really make any influence. So, you know, I think the crisis has provided opportunities to raise these issues in a political sense, but I'm not optimistic that we'll get very far.
Can I add a couple more things to it, actually? I mean, I think there is something we can all do, which is moving away from your question, Jo. That I think we've become very seduced by the lifestyle discourse. You know, it's all about lifestyle choices. I think we really have to get a bit smarter, because for many people who have health issues, it is a life course issue, not a lifestyle issue. So the language is cunning, it's clever, it's all about individual choice, that you're obese or that you have a poor diet. Well, for many people, health issues are, I mean, frailty, for example, occurs to people 15 years, poor people 15 years earlier than it does for people who are well off. I mean, it's very stark. And I think we have to be able to willing to challenge that narrative. Yeah. There seem to be some questions in the chat room.
Yes, if that's okay, Alison, I've been writing down the order. Rakesh, you had your hand up before any typed up questions turned up. And Judith, I know you posted yours first, but if it's okay, I'll hold it to the end.
Yeah, sure. Yeah, definitely.
So Rakesh, please unmute yourself if you can and go ahead, ask your question.
Thank you so much. Can I just thank the professor first for the excellent book, which I look forward to reading, but also the webinar today as well, and to Vanessa for introducing us to the webinar. Two things really. I'm an acute response team GP, but also work in end-of-life care and frailty locally. Two things really. Only 10% of health really is determined by what we do in healthcare and so on. A lot of it is around other social determinants, as the professor said. But the other thing that's really interesting is that in a recent BMJ article, it was said that there are 3 times as many care home beds and citizens in care homes over the age of 65 than there are national hospital beds. And yet again, we focus so much on hospital beds, and the patients who are in care homes and also the old and frail who are in their own homes, we don't seem to be able to offer the support and focus that they genuinely deserve to enjoy better quality of life. And when the end of life comes, it is a dignified end. So I completely agree with her. The question really is, how do we as a society and wider health and social care professionals move the focus to where it should be?
I mean, that's a really good question. I think that there's been, and I actually am a massive fan of the BMJ. My mother's a retired doctor and she gives me all her BMJs when she's finished reading them. And I think the BMJ has covered itself in glory, actually, over the whole issue of the pandemic. It's really squarely said this is a political issue. It's shameful the way that older people have been treated. And you'll be aware, I'm sure, that there's a call for a universal social care offer. That's been spoken about before. But again, I think there's more impetus for that, including care homes, but including home care services and the other social care issues. I mean, one of the challenges, as you've implied, I mean, the hospital issues are very visible. And one of the arguments I do make in my book in relationship to dementia and frailty is that there's almost too much focus on medicine and not enough focus on social care. The social care is disproportionately, you know, ignored in literature and in political discourse, when actually for people with advanced dementia living at home, it's much more significant a part of their lives than the kind of health professionals, which is not in any way to suggest that health professionals aren't important. That's not what I'm saying at all. But it is that we struggle with social care. It's this blobby thing that people have to pay for, that the local authority sort of are involved in or not, or self-funders. So we struggle with what social care is. We don't struggle with what healthcare is. We all have a GP, we know what a hospital bed is. And it's quite an unsexy subject. But I don't know the answer, but the universal system, the universal social care offer is being much more spoken about now. But of course there's the whole debate about funding, which must be, in my view, the way forward is to have a proper discussion about how you develop a universal social care system and funding at the same time. Because what we've done in the past is we've had discussions about how it might be funded completely separate, mainly long-term care, completely separately from any attempt to reconfigure the infrastructure of how social care is managed. And I think the care home agenda has highlighted some of those weaknesses. But it is a political matter. There's no escaping it.
Thank you.
You're welcome.
I'll go on to the next question if that's okay, and that's from Vanessa. She's asking in the chat, how do you think new ways of delivering healthcare, which are now being pushed, such as remote working or telephone contact, email consultations, how do they impact on relationships which clinicians and carers have with patients, and this impact on loneliness and subsequent mental health that you talked about before?
I mean, I don't know, actually, is the truth of it. I haven't particularly taken attention to that, but I am aware that there's evidence that where care homes in particular have attempted to engage older people remotely with their relatives, for example, it's been a mixed bag. In some places it's worked well and some people find it fine. In other places, perhaps if the person's got more advanced dementia, it's just been confusing for them to see their relative's face on a Zoom screen and not actually been able to sort of touch them or see them. I think we've got to be a bit careful, actually, that we don't all rush to the sort of, you know, to online or remote agendas as being the answer. I think they are. I think, you know, you're a GP. I'm sure there's often examples where you've thought, God, I don't know why I didn't need to see that person, actually. I really could have just diagnosed them over a Zoom chat. But I'm sure there are many examples where, you know, and I read a GP article in the BMJ about this very issue, saying, I think she called it I Miss the Silences, McCarthy, that's the name, the GP. And she said, but you don't see that person's face. You don't see the change in their expression. You're not able to sense that they want to say something else to you. And I think if we're not careful, we rid ourselves of the depth, of the richness, of the quality of relational support and relational care. And that is why I've always been not a big fan of the kind of artificial intelligence stuff. I'm a bit skeptical about that in long-term care. I'm not saying it has no part to play. I'm not going to be, you know, a Luddite about it. But I do worry about us rushing into the arms of, well, hugely profitable companies, frankly, who think they've got an answer to a problem or an issue that we, all of us in this event, know is complicated and is about human beings. And I really worry about the human component of going to the GP, the human component of seeing a social worker, the human component of, I mean, you know, even an ordinary chat with the shopkeeper. I mean, I just worry about what you lose if you don't see people, which is not to suggest there's no role for it going forward, but I'm nervous, particularly with older people, actually, who have a tradition of not sharing their problems. A lot of older people aren't keen to, and they might just about divulge it to a GP face to face who they've known for 10 years, but are going to find it hard, I think, to talk about their concerns about looking after their relative with dementia, who they're really struggling with, their challenging behaviour. That's just not a conversation that I think can be had over a computer. So I think it's about being honest. I think it's saying, yeah, you know, there are plenty of examples of online conversations that are fine, online consultations that are fine, but not these more nuanced, complex ones. And I guess for a GP, that's quite difficult. I mean, and I'd be interested in your own reflections, actually, Vanessa. You're muted.
Yeah,
that's it.
So I mean, I think I feel very similarly. Actually, I'm really worried that we'll push too far to remote working, and there's, you know, there is I think within the CCG kind of nationally now, they're very keen for us to do a large proportion of our work remotely, virtually, through telephones, through video consultations. And I think for me, it's you absolutely lose a lot of that personal connection. There will be some patients, particularly older people, I might be the only person they see each month if they come in, and I think sometimes they come partly just to have some human contact, actually. And I think also I remember a depressed chap that I was seeing, and I didn't even realise I had done it, but he said to me, you know, the last time you saw me, as I left, you touched my shoulder, and actually that was the first time that I actually felt like someone cared. And I didn't even realise I'd done it, but I think it's those little things that actually you get from actually being with someone, and I think you know, it does worry me. I agree with you, and I think it's true. I think for older people particularly, but actually also younger people, but particularly mental health.
I certainly wouldn't say by any means it's just older people, but I think that an older person coming to the GP maybe bringing to that conversation a number of issues. Okay, they've got a kind of health problem, but there might be their health problem. They might be worried about their partner who they're caring for. They might be worried about, you know, other matters which they might share with you if they've got, I know you've only got 8 minutes with them or something, but if you know them well, it's much more likely that they would bring those other issues to the fore. Yeah. I think we've just got to be careful. I think we've just got to be careful before we chuck the baby out with the bathwater, I think.
Thank you.
Thank you, Alison, and thank you, Vanessa. Next, we've got a comment from Nancy. She says, good to hear there are legal challenges. It's felt like a shameful situation how care home staff and residents have been treated. Perhaps you can comment a little bit more on the legal challenges and human rights issues?
Well, interestingly, I'm apart from being part of a group that people who are actually on the event chat also belong to. I've mentioned it to quite a few students, so apologies if I'm repeating myself, but I belong to a group of gerontological social work academics. We call ourselves the G8, and I can see Sally and Mary Pat Sullivan as well from Canada, who used to be part of the gang in the UK, who've joined us today, and Judith actually was one of the founder members too. So we collaborate around older people's social work, but I'm also writing a paper with a Euro group, a special interest group of European academics actually who work in social work on this very issue. And we are taking a human rights approach and a social justice approach to unpacking the care home crisis, the care home deaths, preventable deaths. And I was quite keen to try and make a sort of case for what you might call culpable homicide, or whatever the equivalent is, because it feels to me that if you argue that a lot of those deaths were preventable, then somebody could have prevented them. And I would certainly say that the government is in good part responsible for that, despite what they're saying at the moment. I think we're going to go down the route of human rights, including quoting, you know, United Nations and World Health Organization, you know, that people have a right to be protected. Staff as well as residents, by the way, have a right to be protected and work in a safe environment. So that's one strand. Another strand is an issue about ageism and social justice, that older people were just left to get on with it and nobody paid any attention to the care home sector. So there's a real ageism, social justice and ageism agenda. So that's at least 2 strands, and there's probably others. And of course, there's the actual legal challenges, and one of which I thought was very interesting. There was a very good paper by a lawyer, Oliver Lewis, a barrister in community care, saying that people who are subject to deprivation of liberty safeguards in care homes were put there because it was in their best interest and it was the safest place for them. But in the COVID crisis, it wasn't the safest place for them. So technically, the local authority should have been reviewing those DOL's decisions and moving the older person to where, I don't know. But that's not the point. Lawyers are not worried about the practicalities. They're worried about the kind of ethical principle. So I think there's several strands to that argument. But people died. They needn't have died. And they died alone without a human hand, to go back to Vanessa's point, without a comforting hand, with no medication. And some people died in Spain and France, French and Spanish care homes, and probably ours, let's not be naive, of without food and water. So I think I've answered your question. We're only in the early stages of developing the arguments, but it's going to be at least 3 strands, as I say, including the staff, not just the residents. But we now think that at least half of the deaths related to COVID are going to be from care homes. And by the way, it's not just about dying of the virus, it's dying of not being allowed to be admitted to hospital, GPs not attending care homes, and treatment not being offered for people with non-COVID related health conditions. It is just an appalling abandonment of any kind of leadership or responsibility. The slight risk, I think, of pushing too hard at the legal door is that the government will say, well, actually, the care home is the legal entity. The care home is legally responsible, if you like. So we can do what we like, but it's not our problem, which is what they're already doing, obviously. And they've never taken any responsibility for it at all. So I think there are some problems about what you might say, what do you then do about that? But let's articulate the arguments first, which we're only halfway through doing. Does that sort of answer your question?
Nancy has replied in chat, just with some kind of caution around time. I'll just direct people to a few comments that are appearing in chat in relation to the legal issue. So please feel free to read through them. Because they're not questions, I'll probably revert to the next question if that's okay. But Alison, it's your book event, so you tell me which way you'd prefer it to go.
Easy. I'll go with whatever you think, Russell.
Okay. In that case, we've got a question. Gosh, we've got quite a few questions. We've got a question from David, who's asking about the content of your book and the focus of your book. So from which countries has your evidence-based principally been drawn? Has it included those countries, such as parts of the Southeast Asian countries, where attitudes to older people are formulated to a degree by the more attention paid to life course considerations?
It's a short answer, actually. I'm sorry to disappoint, but not really. The book is, I did draw evidence widely from lots of different sources. Mainly, I'm speaking to an audience in the UK, Europe, and I think North America to a less of a degree. I was conscious throughout that I wasn't paying enough attention to other countries, frankly, particularly countries that haven't got well-developed welfare states. I acknowledge that, and I acknowledge it in the end of the book as well, which is not to say that a lot of it isn't relevant, but I just had to admit that there were things I couldn't include. I did include, although I say it myself, a massive amount of material, and I didn't pay as much attention as I think it deserves the rest of the world outside of Europe.
It wasn't a criticism, Alison, it was just a question.
Well, it's a question, and I didn't know. And I didn't look at people with lifelong mental health problems. They were a population I didn't particularly focus on. And I didn't focus on people with learning disabilities. So, and again, in the end of the book, I say, look, these were what I've said is there were things I had to pay less attention to, and those were some of them. But I think there are real questions, and look at what's happening to the COVID. Look what's happening with COVID in some poorer countries well-developed welfare states. In a way, that's just, those questions are just huge there, aren't they? About hospital care, who gets access to treatment, who gets access to care and support. Yeah, it's a huge question. I do, by the way, talk in the book about gender and race and cultural issues. So I definitely do pay attention to the fact that that Black and minority ethnic communities are much more exposed to inequalities throughout the life course, and those are risk factors going into later life, and some cultural attitudes, yes, a little bit, but not enough probably.
As you're on that topic, Alison, I'll jump a couple of questions down to Bridget's question that is exactly about this. So she's wondering if you're able to share your thoughts on challenges facing BAME older people in our communities.
Yes, I mean, happily. I think that, well, obviously the term BAME is a bit of a problem, isn't it? Because it's an umbrella term, which I'm not entirely comfortable with, because I think it captures a lot. We fail to see the nuanced differences sometimes when we use that term. But given that that's what we've got, I think, as I said just now, there really are issues about unpacking the risks, the life course related risks that older people from BAME communities bring to later life. And we know that Black and minority ethnic older people have often experienced, well, for a start, they've experienced exposure to racism, and that is a risk, that is a health risk, psychosocial stress in particular, that they're more likely to have experienced poverty, they're more likely to be in manual jobs, they're more likely to have been exposed to poor housing. So they enter later life with life course inequalities writ large already in their lives. What there is evidence about, interestingly, is that Black older women, there's just some research that was done with them, said that actually ageism eclipsed their experiences of racism, that they were more robust and resilient in terms of, kind of, as it were, experiencing discrimination. But they said once they got past a certain age, their experience of ageism actually was more damaging to them and their daily lives than their life course experience of racism. But of course it intersects, intersectionality. Again, you'll be familiar with this. I think there are a host of issues in relationship to Black and minority ethnic older people, which we haven't even begun to think about in the UK. I think we've got a lot of work to do there. But I think the inequalities lens adds to the discourse quite powerfully. And we need to understand the word need and healthcare problem just through that lens, through that inequalities lens, to a much greater degree. And that, I think, will bring to the fore the issues I've just talked about in relationship to Black and minority ethnic groups.
Thank you, Alison, and thank you, Bridget, for the question. Sally's asking next, will the crisis in jobs for young people and Brexit mean that labour force in social care will remain an issue?
I mean, I guess you could argue there's an opportunity here. And I was listening to the radio an hour ago or whatever, when they were talking about Rishi Sunak's, announcement about trying to create new jobs. And you wonder whether there aren't opportunities to attract younger people, not necessarily young people, but younger people into the social care workforce in a creative way. I know you're sitting there thinking, well, what's the creative way? I don't know what that is, actually, but it feels like we need to do much more work to try and engage younger people in permanently, or at least in the long term, working in the social care workforce. Now, we fail to give people careers, opportunities, we fail to give people proper pay, we fail to give people proper conditions. Unless we do tackle those infrastructural issues, then I think it's just going to be the same old, relying on goodwill and people being on 0-hour contracts and so on. So it takes us back to the discussion we had at the very beginning of this. I think we've got to make social care more attractive, actually. I don't quite know how you do that, Sally, actually. It feels to me there is a role for local homes, for local markets, local communities, because I know there are some fantastic care homes. We've got to be careful here. There are some fantastic care homes owned by families that have been run for years by the same, absolutely fantastic care. it's really the big boys that we need to be most worried about. It's the big players, and they're not bothered whether they employ a young person or not. They just don't want to pay them very much because they want to make a profit. Those are the priorities of those organisations. And as Chris Phillipson says in his webinar the other week about care homes and COVID, unless we're willing to confront the clash between efficiency and effectiveness, that a profit motive is not ever going to deliver you terribly good care, because it's going to always be the priority for you. It feels very difficult to talk about good care unless we confront that issue.
Because my question very much follows on from Joe's. And I guess in terms of the political situation, I suppose I wonder whether any of those things are possible. And I agree with you, that's the way we need to go, whilst social care is still the Cinderella at the Department of Health. Until that issue is dealt with, and until we have the long promised social care bill, whether we can move forward on that. What do you think?
I don't know. I mean, I think it's interesting that Matt Hancock, well, two things. Jeremy Hunt was on Radio 4 some weeks ago saying extremely hypocritically, oh gosh, look at these care homes, it's dreadful what's happened in them. It's made us all realise how important social care is. We should really recognise social care workers. And then I thought, I thought you were the first Minister for Health and Social Care. I'll just double check that. So I double checked it. And sure enough, he was in fact the first person to take the title partway through his ministerial stewardship, if indeed you want to call it that, of changing from being Minister for Health or being Minister for Health and Social Care. So there is this level of huge denial and hypocrisy kind of right at the top. And Matt Hancock, who was meant to be Minister for Health and Social Care, forgot about care homes during the COVID. So it does fill you with gloom. Fill you with, I don't know, yeah, it fills you with a bit with gloom. We need more powerful people to really step up to the plate. I mean, the Labour Party needs to do more specifically about this. I'm happy to help if anyone wants me to. Can I answer the question about social? Somebody asked about social work, Greta. Can I just answer that question?
Sure,
because I do feel quite passionately, as those students who are here know, that I think social work, one of the messages from the book is that as social workers, you need to understand how that person has come to be where they are at that moment. So you will have been sent out to do an assessment of need because somebody qualifies in the Care Act, under the Care Act, or some such statutory principle. And I think you've got to sort of almost put that to one side when you get into the room and try and get to know that person, get to know what matters to them, and try and connect what is happening to them at that moment with what's gone on in their lives. Because most people want to tell you, you know, I used to be married, my wife died, or I used to fight, I was in the military, let me show you a picture of my family. These things matter because they tell you about the person, and they move you away from thinking just about that person's need. And don't forget, you're seeing them, often you're seeing them at a point of crisis, or when they've got very complex needs, because local authorities don't see anybody else these days. But that is actually even more reason for you to try and take account of what's happened in that person's life. Because I would argue you can't understand their needs. Sally, you would back me up 100% on this, and Mary Pat. You can't understand somebody's needs unless you really talk to them, understand them, build up this magical thing called a trust relationship. And a lot of that will be about listening to what they've got to say about what's led them to where they are. You know, they weren't always an older person living in a bungalow with a dog with depression and lots of complicated medical needs. They were once, you know, a dashing major in the armed forces, or whatever it is. It's because you really need to understand. I mean, if someone visited you and took 20 minutes to, I'm not saying this is true for social workers, by the way, but yeah, I know how under pressure social workers are, but we've really got to as it were, recapture what matters in people's lives. And that, I think, is about time, really building up a relation and trying to go back and see that person. I mean, I was talking to a student the other day about someone who's about self-neglect. And I was saying, now, I'm sure I wouldn't be allowed to do this, but if I was a social worker and someone was referred to me who was self-neglecting, I would go around to their house and I would just talk through the letterbox for a while and just say, if they wouldn't let me in, I'd say, I'm going to come back next week and chat to you. I wouldn't do anything about self-neglect. I would simply try and build up some sort of rapport with them, and sooner or later, they'd probably let me in. But I wouldn't come all guns blazing saying, oh, your neighbours are worried about you, they think you're self-neglecting. I don't think any of that's complicated. I realise it's going against the grain, which is to get things done quickly. But I just wanted to answer that question.
Thank you, Alison. I feel I need to make unpopular decisions now with the eye on the time. So the names I recognize, the names I know that may meet you in the corridor, if ever we're allowed back in the same corridor. I'll leave those questions to last and prioritize questions of people whose names I don't recognize. So John is asking, is there potential in the new community development approaches, so local area coordination, social prescribing, and other such, to support relational citizenship approaches better?
Yes, I think there probably are, actually. I mean, I'm not a huge fan of social prescribing, not because I don't think it's got any legs. I mean, Kate's still here on the call, so I'm sure she'll back me up on this. There are great examples of social prescribing, but I think some of this, and I would emphasise the some of it, is frankly the sort of stuff social workers used to do with another hat on, and it's become kind of sexy and acceptable because it's under the kind of NHS, and it's called, I mean, the word prescribing says it all in my view. It's trusted, it's safe, it's seen as something that people are going to do, even though actually, as far as I can tell, there's no prescription involved, or there is. It's like, here's a community group, off you go and attend it. But if the person doesn't attend it, then their prescription is sort of torn up and no one's any the wiser. I think you're right, though. You're implying that there are new models, and do those new models offer us a chance to reframe, rethink, engage with citizens, use relationships to empower, genuinely empower, not just empowering on paper, and think about communities differently? Yes, I strongly think there are opportunities for that. What I would say, though, is evidence suggests, and this won't surprise any of you, that the people that are often left off those initiatives are the hardest to engage. So older people living alone, older people with dementia, stress carers who can't get out of the house. In other words, I think the abstract concepts have got to land in real people's lives. And for my money, the acid test is not the person who's actually easy to help. It's the person who's struggling, who's perhaps not so visible and needs those initiatives. But I didn't show a table that I had on my slides, but it's in my book, which talks about kind of national societal level initiatives, community level initiatives, and individual family level initiatives. So there's a sort of read across between tackling poverty by policy means, making sure a community and environment is enriched with shops and public transport and access community resources, and actually helping people alleviate poverty at the individual level. So I think those sorts of initiatives have that potential to be the sort of fulcrum for some of that thinking and development.
Thank you, Alison. We've got a comment from David where perhaps you could respond. He says, at the moment, the internal group in government working on the social care funding proposals are still struggling over whether this is a society problem or an individual issue. Is it difficult to arrive at a funding method, let alone a funding quantum, until a decision on the former is taken? Perhaps you can comment on how those narratives around individual versus society problem can be shifted, or what we can do about it.
I mean, I don't think it's complicated. I think it is a societal problem, in the same way that the health service is a societal issue. Healthcare issues we accept, I know it's being eroded by the current government, I'm not naive, but we accept collective responsibility at some level for the care of citizens who are ill. We all say, yes, I think it's fair that we pay taxes to support people who are ill, because it's not their fault they're ill, it could happen to any of us, kind of argument, although that's not true because of health inequalities, but let's leave that to one side. I've made that argument about 20 times already. But I think in terms of social care, at the moment, we don't have that understanding of it. We're a bit mixed up about it, we're confused. We're uncomfortable with old people dying in care homes. But when it comes down to it, are we willing to be taxed more in order to pay for that? I think the jury's still out on that. But I think Dilnot, if I put my money, nail my flag to the mast, I'd say for a funding model, Dilnot was one of the best. I think he really did come up with a balanced, manageable way of dealing with the funding issue. And one of the things I remember him saying quite strikingly was, we can't have an insurance model in our social care insurance model in the UK, because until the government decides what it is and is not going to pay for. In other words, if you don't nail down the goalpost fairly firmly, the other elements of a system like they have in Germany and other European countries just won't come to the table. Judith, did you want to come in there on that at all?
Sorry, I couldn't unmute. No, I totally agree with you. I think we do need a new model, and I think this is really where, you know, the crisis has exposed the differences between health and social care starkly for a number of people, probably more than it's ever done before. But you know, Dilnot is, I think that's the only thing that's on the table at the moment. I think it needs to be resurrected. But I think there's a lot of ignorance around social care in government. I mean, you know, from first-hand experience, I can tell, you know, there is a lot of ignorance. And so I think there's a long way to go. But Dilnot is one good model. I think you're right there.
But I think, to go back to the issue, we've got an individual model at the moment. That's the model we've got. And I think we've all got to agree it's not very good. So I'm not, in a way, I'm not quite, we've got the not very good model now. For it to be better, we've got to shift from what is currently a very individualized way of thinking about social care responsibilities towards something that looks more collective. Now, you know, I think we can debate how that might happen, but I do honestly think if we want a universal care service, then you've got to pay for it. And it's got to be something resembling an equitable system. I think there's a lot of ignorance. I agree with you, Judith, not just in government, generally. People are really naive about social care funding. When I've worked at the University of Kent for years, and like recently I had a conversation with someone, it can't be that recently, can it? Because I haven't been there for bloody 3 months. But anyway, sometime earlier in the year, was bumped into someone in the corridor, an administrator, and we were talking, oh, my dad's ill, might need to go into a care home. But when he does, of course, the NHS will pay for it. I said, I've worked with you for 20 years. It's like, it's not, people just don't want to kind of think about it, even though they rationally know that perhaps isn't right. It's a sort of weird mixture of denial, ambivalence, and I'll bury my head in the sand and hope it goes away. Do you know what I mean? Yeah.
Well, we've hidden it away. I mean, I always think that academics in, you know, long past did a disservice to residential care when they rubbished it, and we never came up with an alternative.
Well, that's what Chris Phillipson says, by the way, Judith. Chris Phillipson, who's another big noise in the gerontological world, he says that the gerontological academic community have ignored for the last 20 odd years, or 10 years at least, care homes, and should get back on the political horse and stop demonizing it.
Yeah. And you know, our solutions have come through housing, you know, and supported living examples as a preventative thing rather than focusing on residential care. And we do have to get back to that. Sorry, I'm interrupting.
That's fine. No. Shall I mean, I'm aware of the time. I mean, I'm quite happy to carry on rambling. I'm just getting bored with myself, to be honest. So I mean, really happy if people want to hang around. There's a couple. Do you want to pick a question?
I will do, if that's okay.
Somebody asked about how to get the book. So I think
yes,
we should.
I'll type that in just a second.
Okay, fine.
So wait, and also all the information about the event that is still available, your Eventbrite link where you registered has both the discount code and the link to how to get the book. But I'll paste it just as soon as I raise the next question. So our alumna, Emma Bint, is asking, when you did research for your book, have you found any common themes that older people had experienced in their younger life that was, in inverted commas, responsible for their ill health now? And if so, what were they?
That's a really good question, actually. I mean, of course, there's no such thing as a group of older people. They don't exist any more than a group of younger people exist, or a group of any sort. Because one of the challenges, which I did curse and beat my head against a wall over, was the fact that when you're talking about older people, you've got to take account of cohort differences. You know, that people between 60 and 70 will have had a different life course and different experiences than people aged 70 to 80 and people aged 80 to 90. There is some assumption that anybody over the age of about 65 until death is later life, and those people have all experienced the same life. Well, of course they haven't. In no way has a 20-year-old experienced life in the same way as a 40-year-old. And somehow when you're old, everybody's old. So that was just a real challenge. But what I would highlight is, if I may for a second, thinking about women, older women, and I do talk about them quite a bit in the book. If you've been in an abusive relationship, domestic abuse, a trauma relating to children, perhaps death of a child, having a child removed, very unhappy younger years, being neglected by your parents, and of course poverty, and this is one of the running sores. If you've experienced a cluster of adversities, which is both socioeconomic and personal, those issues will undergird your health, will damage your health going forward. So I mean, I'm not sure it's a single issue, but I would say sustained abuse, whether it's as a child or as an adult, will damage you. Yes, that's something that whose thread. And there is another, again, there's a tendency to think about older people who might have had a botched abortion years ago, or had a stillborn child, or were raped, or domestically abused, that somehow when they get old, that's sort of deleted by being old. It's like, well, no, of course it isn't. And I would be critical of people like Michael Marmot, who is, by the way, one of my heroes. If I ever met him, I think I'd just faint. He talks a lot about inequalities and how powerful and profound they are in affecting health. But unless I've got this wrong, on the whole, he takes the view of dragging it into the life course up to about midlife. It's quite interesting. We're quite reluctant to kind of extend that thread of damage and advantage, both, by the way, before you think it's all gloom and doom. There are advantages that people who have advantage life courses, I can define what's good about that. He hasn't really extended. That was one of the aims of my book, actually, was to take some of those arguments and as it were, keep going with the thread into later life. So I think a very adverse childhood and violence or abuse. I mean, war veterans, they're a particular group of people who have real traumas in later life. I mean, one of the cruelties, I think, is if you have buried your wartime experiences and you've perhaps dealt with them by drinking heavily or whatever, when you perhaps get dementia later on, you can't use those protective mechanisms. There is evidence that the trauma actually might happen to you for the first time if you've never experienced it, and I think that must be so cruel. Or you're re-traumatized. You know, you're not in charge of all your protective mechanisms. So there's some quite interesting issues there.
Thank you, Alison. We've got a comment from Daniela, who says she's got an 8-year-old mom who's trying to live as independently as she can, and that the COVID crisis has made older persons more dependent on others and family support, and that she hopes older people will be able to get back to some self-confidence.
I mean, it's very
relation. Sorry, go on.
Very good question. I think, I mean, it's quite sort of, we've all had to reflect on this a bit, haven't we, right? We've all been lockdown. I don't know about Mary Pat Sullivan quite so much in Canada, but we've all been really locked down in the UK, in our homes, with our families. And if you live alone for months now. And I was sort of half joking with a friend of mine the other day when they said, oh, you're allowed to go out now. You almost cowered in the corner of the cage. It's like, oh, the door's open, but oh, I'm a bit nervous about going out to the high street. So I think if you're an older person and you're being supported, your confidence levels will probably have dropped. Yes, I think there is something about understanding that your mum would probably need a bit of a sort of almost a reintroduction to sort of some of the stuff she used to do. I think we've all got to admit we've lost confidence in a lot of social activities because we haven't done them for 3 months. It's not that complicated, but of course, if you're elderly and a bit frail, you're going to probably be even less confident and worrying about how am I going to get back. And there certainly is evidence now that the mental health challenges of COVID are beginning to kind of overtake some of the sort of physical risks for some of us. I can't comment obviously about your mum as an individual, but I think it's been kind, and it's helping her to re-engage with some of the things she used to do, which probably means you've got to do a bit of that with her and then gradually sort of withdraw. But it is getting back on the horse. I think we've all got to do a bit of that. But I think for some of us it's a bit easier.
Hi.
Hello, Daniela. We can hear you.
Hello. Sorry. I hope I didn't interrupt you. Thank you for that. That's great. That's really helpful to me to hear that as well. I don't work in this sector at all. I work with people with learning disabilities. Actually, I'm an employment advisor, trying to find people jobs, but I do work with people with mental health issues as well. And it was just an interesting topic for me just to explore this with you today. So thank you. It's been great. But as far as my mum goes, what I'm doing is I'm slowly, it sounds really weird, but I'm going out. I'm asking her, would you like to go for a walk? She has health issues as well, and she has a little walker. So I'm saying to her, would you like me to go out for a walk with you? Where would you like to go? And she's choosing. I'm trying to give her choices. You choose. What do you want to do? Oh, let's go down this way today. Okay, let's do that. So she's getting more confident. We've been doing this for a while. Even before the government said, oh, people who are vulnerable, shielding can go out. We did it a little bit earlier, but just really carefully avoiding people.
That sounds brilliant, honestly.
So that's what you've got to do. You just got to get the confidence back and try and, help them make choices and say, you decide, don't take everything away from people.
Well, I think that you're right, though. I think a lot of people, not just older people, but particularly perhaps older people, they're talking about deconditioning, aren't they? There's a lot of stuff in the BMJ, my favourite journal, talking about people being deconditioned. So, kids, everybody hasn't been doing the usual amount of going out and doing exercise, and older people haven't perhaps been going for their usual walks or seeing their friends and things. There is real worry about deconditioning. And I think if you're older, that is an additional problem. So, not having done your usual walks and exercise will have set you back kind of physically, and there's the isolation, worrying about how I'm going to cope with meeting friends and things again. There's a whole discourse which I haven't got time to go into now. The British Society of Gerontology talks about this a lot. We've got to be a bit careful. They criticise the COVID discourse for being all about age and potentially ageist, but actually what places you at risk is having health vulnerabilities, which is definitely the case for people who are very old, but it's also the case for some younger adults too. And just to see it as people over 70, when plenty of people in their early to mid 70s are very fit, when some people in their 30s aren't, is to see it in a rather simple light, and feeds into a narrative about older people being ill and needing care and using up resources and that sort of thing.
Thank you, Alison. I think we've got time for a couple more questions. Perhaps I can promise that if I recognize your name, I will extract your questions and Alison may, I don't know, email you individually. Too big a promise to make, Alison?
No, that's fine.
Got too many of those questions.
No, absolutely fine.
I'll go through a couple remaining where I can't recognize the name and the person is definitely still on the line. They're showing up as still kind of present in the meeting. So, and Jennifer is saying, I assume that the likelihood of being prescribed medication and not being referred to therapy increases with age and is also reflective of ageism. How can we increase the availability of therapy and counseling, particularly post-COVID?
Very good question. I do cover that in the book, yes, and I talk about the fact that there is evidence, quite strong evidence, that older people are more amenable to psychotherapeutic interventions than younger people. So you can teach old dogs new tricks. So it is plain ageism that we don't offer older people therapy, CBT and the others. And there is just no evidence that it's not effective. In fact, the opposite's true, it's more effective, which I think is quite a striking piece of evidence. But your question wasn't that. Well, although it helps to be able to quote that when people say, oh, you know, old people, they can't change. Well, actually, no, there's no evidence that therapy isn't effective. I think it's partly about challenging the narrative. So when you're in meetings or when you're going, I don't know if you're a health worker, or when you're going about the place and people say, oh, you know, we don't offer therapy to old people. Obviously, we don't. So, well, why is it obvious? And also, what is old? Is it people in their, well, people in their 60 is the new 40 and all of that now. So, you know, you kind of wonder where this stuff comes from. And certainly the stuff about IAPT services, don't forget that was driven by people, by an agenda which was about getting people back to work. So if you have got mild anxiety or depression, the IAPT intervention meant to be getting you back to work. But that was challenged, for those of you who are interested, and older people were subsequently offered IAPT, and as I say, quite successfully. But you're right, there remains an ageist set of assumptions about older people being given pills and younger people being given therapy. I don't know this, and it could be prejudicial on my part, so feel free to challenge, but there might be a slight anxiety on the part of some health professionals, thinking, I don't want to offer this person a therapeutic intervention because they might be uncomfortable with the idea of that and might be more comfortable with taking a pill. But I think as a health professional, you've probably got to be a bit bolder there and say, look, there are ways forward here. You know, here's one way forward. And if that person says, oh, no, over my dead body, well, then obviously you can't push it onto them. But I think we are gradually beginning to open up that. I think my sense is that therapy is now more available to people of all ages. But I don't know how many older people have therapy compared to younger people. I don't know the answer. And also, what's therapy? Therapy is lots of things, ranging from a 6 weeks course of CBT, don't know if Kate's still here, yes, she is, all the way up to years and years of psychotherapy. So, I mean, again, I think we've got to be careful what we're talking about here. I mean, for example, there's certainly evidence that targeted interventions to help people manage bereavement, which is more of a common experience in later life, can be very effective. But then John was making the point, or John was asking earlier about kind of some of these new community initiatives. I mean, you could argue that some of those initiatives could be used to reduce loneliness. They wouldn't call themselves that, but they would be attracting older people who perhaps are isolated, living alone, in order, and Martin Stevens talks about that, you know, in York, that community initiatives to tackle problems that individuals experience but are social problems, which isn't quite therapy, but it's about coming at the problem from another angle.
Thank you, Alison. Perhaps just 2 more questions. We've got one from Anne, who works in old age psychiatry, who's asking for advice on how mental health services can work with social care in order to maximize the interplay between the two for the benefit of the client.
I mean, I don't want to sound like a sort of miserable old bag, but I mean, Sally in particular, I think, will, you know, here, and possibly Jenny Collinson as well, will know that the issues of integration have been called for since Seabohm in the 1970s. So the integration agenda is very important and is sometimes quite good in some settings, but has never been cracked. That nut remains firmly uncracked. And that's partly because of funding. Let's not go back over that ground. The whole system, the whole infrastructure of social care is just completely different to the infrastructure of the health service. And certainly there's been initiatives, I can't remember what it's called now, to do with GPs doing work with care homes. You might know actually, Vanessa, where GPs are being encouraged now to go into care homes. But it's historically been pretty variable and random. If a GP practice wants to go in and they're good, they do it. And if you're not living near one that does it, you don't get it, which cannot be acceptable. But I think, are you asking specifically about, I suppose social care is a pretty broad idea. Can perhaps you be more specific? Who asked the question, Russell?
Anne, if you can unmute yourself. Oh, yes, you're unmuting yourself.
Yeah.
Go for it.
I guess it's because there's always this divide. I mean, I work mostly in community at the moment, but yeah, we have care homes, we have all sorts. I mean, it's always there's always that tension, and I guess it's been there for a long time, never gonna go away, and it's a lot of game of like passing the bat a lot of time. Like,
so tell me. So where do you actually work in a mental health team? Did you say? Is that what?
Yeah, I work in Croydon in a community mental health team.
Okay. And you struggle to get access to social care for your service users, do you? Is that the problem?
Not necessarily struggle, but it's always like this tension of like who's going to, sometimes, not always, but you get this tension of like who is going to actually who is like, the patient's almost like who are they going to be passed on to? Like, who actually has to deal with this certain situations? I mean, sometimes they're clear cut, sometimes they're not, and then it's like, who does the initial investigation? Who does this? Who does that? Who does it actually?
I know. I think. I mean, one of the issues. I think in some areas there are very good examples of where I call this the sort of meso level. So you've got the kind of micro, which is you working with your clients, trying to refer someone to a social care service. And you've got a macro policy. In the middle, there are some fantastic examples of where agencies, mental health services, social care, often driven by the local authority, actually, in my own experience, will try and collaborate across, usually inside a particular user group, so learning disabilities, mental health, whatever, and actually come together to develop a kind of strategy, a way of thinking, and encourage. Integration is a big word, but to encourage smooth intersections, that's that word I'm looking for, smooth intersections between different bits of the system. I mean, I would encourage strongly, and I would say this because I teach social workers, for social workers to work in multidisciplinary teams at every opportunity, because one of the best ways of getting social care to people is to say to the social worker, who you know quite well, who you work with every day, look, you know the system, how are we going to get dogs this particular service? But you may say to me, well,
because it's more social work. So I'm a medic, so I guess my question at the end of the day is, what do I need to appreciate with it? Sort of, what could help me to sort of not feel like it is that game of back and forth, but rather sort of appreciate?
I don't think you need to appreciate. I think you're completely right. You're implying that your clients, your patients are getting a raw deal. I'm sure they are, by the way, from what you've said. They often do. I don't know whether you have a social worker in your team, but no. I would. Okay, well, I'll get one then. Make a case and get one. And then you've got someone who can speak to that opaque, strange world of criteria and who pays, and if it's third sector. I mean, my mum was a carer for my dad, and as I say, she was a retired medic, and she didn't understand why she could get carer services for nothing for her, but she had to pay for the day centre for my dad. You know what I mean? It's just bonkers, absolutely bloody bonkers. So for people to come and say I'm a bit confused, you're like, well, actually, it's perfectly normal to be confused because the whole thing is mad. So that's my advice to you. Get yourself an attached social worker. Yeah. Come back and let me know.
Yeah, I mean, one comes into our MDT for like half an hour every Wednesday.
That's no good.
But that's all we get.
Well, that's just rubbish. Argue. Say you need them.
Yeah. Thank
you, Alison, and thank you, Anne. I'm just really conscious of time. I've got one last question from Judah, who had to go because he needs to put kids to bed. But I think it's a very apt question. He's talking about living with an autoimmune disease and draws on people who are older, who, because of their health condition and perhaps age being a risk factor, not only are isolated, but they're afraid of going out, they're afraid of being physically around people. And he's asking what can be done to identify and support the mental health of these older people who are getting increasingly worried, maybe even agoraphobic, or worried about meeting others.
That's a really good question. I mean, I think if you've got a family, because Daniela was talking, wasn't she, about her mother? I think if you've got a relative locally, obviously they're going to be tuned in, aren't they? Well, hopefully, they might, that's an assumption that you might hate each other. But generally, okay, you've got family support around you, or very good friends, or local, or neighbours who are involved in your life. I think, you know, you're probably going to be okay, aren't you? You're going to get back on the horse. But I think there really is a problem. Was it a he or a she? He, is it, Russell, who asked the question? I think it's a really good question about how, well, is it anyone's responsibility to identify people who are perhaps have tipped over into being, from being alone to being isolated to then being lonely? I mean, you know, that's a continuum for a start. I don't know whether it's anyone's responsibility to do it. I mean, I think if you're a politician, you would say it's everyone's responsibility. It's the neighbours, it's the GP, it's the shop, it's the dog walkers, it's whoever. I don't think any agency at this point is going to put their hands up and go, yes, it's our job to sweep round the area and make sure we identify people that are isolated and lonely. I just don't think it is probably nobody's responsibility. Are we therefore potentially creating additional problems? Yes, we are, because of course if people don't go out and they really become very anxious, or they really become depressed, then yeah, they're going to turn up at the GP surgery in their hordes. And could we prevent it? Yes, we could. We could do much more on the TV, on the radio. There are things we could do to help people, but probably the third sector would be the obvious place. Age UK, for example, I'm sure they have got initiatives, but I don't know any that have sprung from the COVID agenda, unless anybody else does. But it seems to me the sort of thing that a sensible third sector agency would be saying, what can we now do now that people can go out a bit more? What can we now do to get people to come out the door? The trouble is, you see, it's all about this individual choice thing. It's back to the sort of the citizen can, but we are beginning to really be worried about the mental health of people who haven't been out for 3 months.
Well, thank you very much, Alison. Perhaps you can offer a sort of informal hangout after this or not, but just being conscious of time, I'd like to draw it to a close. If you've got a burning question, the next kind of short pause is your chance to shout. Just make sure to unmute yourselves. No? Well,
thank you. Can I say thank you to all those people who've stuck it out to now 8:30? And I, for one, I'm going to get a glass of wine now. I'm quite happy to come back and sit at my desk again with it and carry on chatting to anyone who still wants to talk to me. But I'd just like to thank you all so much for giving up your precious Wednesday evening. It's been so nice to see people. I really appreciate it. And thank you particularly to Judith and to Rasa, without whom the webinar wouldn't have happened, but neither would the book.
Thank you, Alison. I started with housekeeping. I'll finish with housekeeping, if that's okay. Just to say, I've still got your contact details on Eventbrite. So in due course, I'll send out both the sort of selected bits of the chat, because some of you weren't asking questions, but you were sharing really interesting thoughts and resources. So I'll collate all that, and I'll send you a link to this video, especially, I mean, me saying that now won't make any sense because those people have left. But if you're one of the people who needed to leave early, either read stories to your grandchildren or put the kids to bed, or for any other reason, you'll have access to the full video, hopefully very soon. So thank you for your attention, and I'm happy to keep the Zoom running.
Okay, I'm going to go and get my wine then.
But also feel free to leave now.
Yeah, you are allowed to leave. I do know you have lives. Thank you, everyone.
And I'll also stop the recording now. So
okay, cool.
Thank you, Alison.
Thank you,
everyone.
I'll see you in a bit, Russ.